Ladies and gentlemen, a very good evening to all. My name is Vishnu Prasad, and I'm the head of Global Operations at Aurolab. On behalf of all of us at Aurolab, I would like to extend a warm welcome to each and every one of you for having invested your time for the webinar that Aravind Eye Care System has risen to provide globally over the time the world has started to confront the COVID pandemic. Many of us across globally have witnessed our lives change differently with circumstances and tasks that one could not envision, nor did we look forward in our lifetime. Now that it is here, it is all about acceptance and the way forward. Given that, the objective of this webinar is to provide our knowledge of sharing our experience when we started addressing the pandemic and trying to carry on our mission of eradicating needless blindness with protection and safeguarding ourselves and those around us. During this webinar today, all participants have been muted due to the number of participants that we have today and the time that is available. However, you are welcome to ask any questions that relate to your region and practice. Due to the time that we have today, few selected questions will be answered live at the end of each session. For all other questions, we have processed your question in person via email. The first topic that we have today is COVID-19 protocols to be followed during cataract and anterior segment surgeries. This will be presented by Dr. Chandrasekhar.
Okay. Greetings to all of you from Coimbatore, a city in the southern part of India. I'd like to thank Aurolab at the outset for this wonderful opportunity to address you people. You all know, in COVID-19 times, protocols have changed. This talk is going to be about protocols for cataract and anterior segment surgeries in COVID-19 times. This is going to be based on the practices and protocols we follow at Aravind Eye Care System based on the guidance and various around the world and in the country. Guidelines given by the national authority and state authority. Recently, the American Academy of Ophthalmology during the lockdown time has stated that the worst affected field in the entire world is ophthalmology. There was a 79% drop in outpatients in ophthalmology, and that tops all the specialties. This is the latest figures of COVID-19. You can see we are heading where more than 12 million people are infected, and we are having more than 200,000 people getting infected on a daily basis. So we are nowhere near the end. We are not even at the beginning of the end. So far in hospitals, in eye hospitals, we have been concentrating on prevention of endophthalmitis, and the concentrated person was the surgical patient. So in that we have conquered to a great extent across the world. Now with the onset of COVID-19, it has become endophthalmitis and COVID-19. We aim to protect the staff, the patients and attenders or whoever that who enters the hospital. So this is how it is going to be in the future. In the broad run, we should not forget the prevention against endophthalmitis as well. A word about conjunctivitis and COVID-19. There have been reports of 1 to 4% of conjunctivitis occurring in COVID-19 positive patients. However, there are not many reports saying that conjunctivitis is the mode of presentation for COVID-19. But we have to be very careful when we have a conjunctivitis in these times. There have been many facts and guidelines coming across the world, mainly from the Center for Disease Control and the World Health Organization, and various national guidelines are coming up. But you can see that these guidelines are evolving, continuous and dynamic. So facts and guidelines changes, our protocols are bound to change. So this is very important to understand that we presume to be working on a patient who is non-infectious and operate on them, but you have to keep in your mind they are likely to be COVID positive patients. In India, the Indian Council for Medical Research has stated that almost 80% of the COVID positive patients are either asymptomatic or mildly symptomatic. So these protocols aim to minimize the chance of spread and not totally prevent. With this background, we'd like to go into some of the basic concepts. The Center for Disease Control says how we should control infections like this. The first is to eliminate or remove, that is when you can treat the person or treat the virus totally. It is not now in our hands. Substitute by ways of vaccine. Engineering controls by way of infrastructural, heating, ventilation and air conditioning system. Administrative controls by changing the way we work, shift system and all those things. People who are under risk category, over 50, over 60, who are at high risk with immunocompromise. And the last in this hierarchy comes the personal protective equipment, but you must say that this is totally under everyone's control. So two people where the chances of a COVID spreading is very less when you talk to anybody. We know it spreads by cough, sneezing, or even talking. That is possible. They spread like this plane, which can be invisible and it can go in any direction unseen very rapidly. This is a stealth aircraft. This is a report saying that you must spend at least 15 minutes with an infected person for a COVID-19 to spread unless he coughs or sneezes badly. This is the latest report. Initially, we said it can come through the fomites. It still can come through the touch surfaces, but that is not the main way it will transmit. Newer reports are coming that they are being airborne. You can see the beautiful corona we saw a few weeks back around the eclipse. But this is the deadly corona which cannot be seen, but it can cause devastating complications and cause probably death in a few percentage of people. The standard precautions which we normally say the patients are all infectious, you have to consider in a hospital, now will become people. That means the patients, attenders and the staff and all the visitors. Body fluids and blood will become body fluids and air around. And all sharps will become used surfaces around. That is how the COVID-19 is going to change the protocols. On one side, we have patient attenders and staff. On the other side, we have the visitors coming in. So the interim infection control guidelines issued by the National Accreditation Board for Hospitals and Healthcare Providers, which is the accreditation board in India and some of the countries around, like the JCI in the US and the West. They say primarily you have to prevent a germ from entering into the facility. Here we talk about standalone eye care hospitals. Isolate symptomatic patients immediately and protect the healthcare personnel. It has been almost 6 to 7 weeks since we started all the elective surgeries after the lockdown. So we have to follow the mandatory regulations. We have to adopt them, adapt some of the possible guidelines given across the world from associations. And there are some good practices probably which can be adapted and used in your system. Some use modified protocols. Some are continuing to operate with the same as before. And near total changes like infrastructural and HVAC changes are being done. Fortunately, till now, there are no major episodes of cluster of COVID-19 occurring after performing elective surgeries. In spite of all these effective measures, there could be a strike of COVID-19. All these pandemics starting from before Christ era have taught us social distancing, wearing the mask for the face cover, and the hand hygiene. Here you can see the plague doctor wearing a beak-like mask which has scent and antiseptics to prevent any infection or the bad smell from the dead. So these are the three mainstays which will continue to be there till COVID-19 pandemic is there and for a surveillance period. Standard precautions like hand hygiene, physical distancing, minimal contact of surfaces, face mask at all times, personal protective equipment as per the risk levels, breath shields, and minimal verbal communication when they are in close quarters. We were fortunate to have in-house development by Aurolab to produce face shields, breath shields for slit lamps, and this is a laser indirect ophthalmoscope with a shield. It gives so much protection. This is a slight modification done in one of our centers, Aravind Hospital, Pondicherry, to create a red eye clinic to give maximal protection. Here you can see an indirect ophthalmoscope with the shield. So these have made it easier and lessens the chance of spread. These are all automated devices to make it as much as possible minimal contact or no contact at any point of time. Our routine workup for cataract will be intraocular pressure, patency of the nasolacrimal duct, blood pressure, and blood sugar. Of course, for intraocular lens cataract surgeries, we have to do the biometry. Anterior segments, other four will remain the same. There have been doubts about using the non-contact tonometry in the early stages of the pandemic. But now there are reports from even the Royal College saying that now it is definitely a safe procedure to do. There is no spread of corona during this procedure. So it can be done with protection, and we've also created a shield to protect the person who's performing the non-contact tonometry. The nasolacrimal duct can be done by Roplas, but it can produce aerosol. A fluorescent dye disappearance test will be done easily, but you have to remember it should be done by a doctor and needs some kind of skill and training. So now we can even do syringing. You apply a drop of 5% povidone and wait for 3 minutes with protective equipment like the shield, the mask, and the glove. You can boldly do a nasolacrimal duct syringing, especially in areas where the chronic dacryocystitis is rampant. The regular blood pressure management, checking up with the electronic apparatus, blood sugar, and pulse oximetry. Pulse oximetry value of above 96 would be accepted as normal. The biometry, ideal way would be to do the optical biometry. If it is not available, the contact biometry, either the immersion one or the A-scan biometry can be done. Alcohol pads, swabs can be used to clean the probe in between. Importance of comorbidities in surgeries are, they can be very, very devastating at times, because there have been many reports where patient comes to the hospital just with breathlessness and chest pain, and they have been lost within an hour or two. So when the stay of the patient inside the hospital is more, then the chances of getting this is more. So they must be worked up, get a physician opinion, and according to the physician, if anything like blood count or X-ray chest, ECG is needed, then it has to be done. It is not going to be very long when a patient asks us, "Doctor, have you your COVID test result done?" So the awareness about COVID-19 across the world, thanks to the TV, thanks to the media and various social medias, it has become so much, everybody is aware of what is happening. So COVID-19 tests are available in some countries, some regions. Depending on the availability, it will be a good method to screen the patient. Only the PCR test can be done. If it is negative, you can go ahead with surgery. We must remember the positivity is only about 70%. If the antibody is available, negative will mean that they are not exposed. If it is positive, you have to do a PCR to make sure that they are not infectious. Ideal would be to combine the PCR and the antibody test. And if PCR is negative, either the antibody, that should be the IgG, not the M. If M is there, they are likely to be infectious, and then you can proceed with surgery with standard precautions and protocols. This is the way they are all sensitive at this point of time. You can see sensitivity is quite low. So you need to be very careful, but it will be better way to screen the patient. Counseling plays an important role. Apart from talking about the condition of cataract or whatever anterior segment lesion is, we need to explain to them about the presence of COVID-19, that they can be asymptomatic, the staff could be asymptomatic, there could be a spread, and that they are aware of it. The attender is only one attender is allowed. They come with minimal baggage. As far as possible, we do a daycare surgery. The scheduling is done in such a way that only people come by shifts and hourly or half an hourly basis, so that there is no crowding of these inpatients in the hospital. The use of mask, hand hygiene, and physical distancing, the protocol should be told and explained to them the importance of all the three. We take this consent form for any surgery, explaining to them about the COVID-19. We have a separate entry point for inpatients who come for admission, so that they don't get confused with the other OPD patients. As always, like the OPD patient, a temperature screening is done, history regarding travel, exposure to a COVID-19 or in a containment zone is taken. The pulse oximetry is done to make sure that it is above 96. As far as possible, we do not do any contact tests. Only a torchlight examination is done to make sure that they do not have any kind of congestion. Slit lamp and contact investigations are best avoided. Electronic apparatus to check the BP, and the drops are applied. Here again, you can ask the patient to pull the lower lid, or you can use a glove or use a bud to pull the lower lid and apply the drops. The patient is asked to wash the face properly along with the hands and the feet. You must make sure that no sentinel event occurs. So make sure whether the correct eye, correct procedure, and the correct patient. And then the ideal PPE for a patient would be the cap, a new 3-ply mask in the OT, foot cover, and a gown. You can use a disposable gown or a clean, sterile gown. This is the World Health Organization surgical safety checklist. Sign in is before anesthesia, time out is before incision, and sign out is after surgery. So this can also incorporate COVID-19 checklist, and we will make sure that all are covered. It can be done under topical anesthesia or local anesthesia or general anesthesia. Now we find that the posterior subtenons is wonderful. So 90% of the local surgeries are done under posterior subtenons. Intranasally, it is given posterior subtenons. We should make sure that the person who is given is wearing a face shield, mask, cap, the gown, and the gloves. In the theaters, most of our theaters have 2-table system. But in COVID-19 times, we have converted to only single patient in each OR. There will not be any 2 patients at any point of time, just to make sure there is no cross-infection. The American Academy of Ophthalmology found out some good facts about COVID-19 and ophthalmic surgeries, and they have proven that this wonderful medicine, povidone iodine, is excellent against coronavirus. The 5% for conjunctival sac and the 10% for decontaminating the skin. Initially, we put on the BP apparatus and the pulse oximetry, apply the drops, and the skin is cleaned with 10% povidone iodine. We have a small frame over the chest of the patient so that the drape doesn't go and irritate the face, so they are comfortable. Make sure that the surgical mask is worn by the patient even during surgery unless there is some difficulty. After draping the patient, the 5% povidone iodine is applied into the conjunctival sac, and a time of 3 minutes is given before cleaning it with the saline. There are no changes in the surgical protocols. It will go on as usual. Only a few things. Shortest time for the procedure is advisable, ideally to be done by a senior surgeon to avoid any complications. If there are complications like vitrectomy, it has to be done fast by the senior surgeon. You should be made sure that there are no spillages during phacoemulsification. The phaco tip and the sleeve are changed between cases. We do not change the handle. So considering all this, today phaco is a very low risk surgery in times of COVID-19. There is no fear about phaco. Only thing, we make sure that the anterior chamber is filled with viscoelastic before we start phaco. So even if there is aerosolization, it will be only the viscoelastic and the BSS solution. It has not been proven so far that the corona is there in the aqueous. The only time aerosolization can occur outside is when we remove the probe outside the wound. At that time, the phaco can cause some amount of aerosolization, and we should be careful at that time. BP and pulse oximetry monitoring is mandatory throughout the surgery. On completion, all the disposable drapes and things are disposed. We apply a drop of 3 or 5% povidone and then patch the eye. After completion, the patient is shifted. In between cases, cleaning and disinfection of all touch surfaces. Team prepares for the next case. The time duration would be depending on the cleaning and disinfection process, approximately 5 to 10 minutes. In a case where we have laminar airflow with HEPA, it is better to wait for 15 to 20 minutes because it gives time for the air inside the theater to be circulated out. All the biomedical waste covers are removed. Touched surfaces are washed, cleaned with whatever solution, either the Lysol or whatever you use regularly. Floor is clean and new biomedical waste covers as per the color coding are put in. Cleaning disinfection is mandatory after every case. When the load is very heavy, every second hourly, it can be cleaned as per the end of day protocol. Post-operatively, we make sure the pulse oximetry is good, patient is comfortable, counseling is done for cataract and post-operative management. Apart from that, we always tell the patient not to go out and meet people for the next 2 weeks at least. It is ideally better to call them and find out about their well-being in between and tell them what kind of symptoms they must be aware of regarding COVID-19, and if they have any eye problems, they should be reporting. If there is a way of doing teleconsultation, the post-operative counseling, post-operative review also can be done via teleconsultation. Personal protective equipment, the protocols are changing by the month and by the week now. All the surgeries in the ophthalmic theater are divided into mild, moderate, and high risk. The only procedure which can be called as high risk will be where we get high aerosol generating procedure with possible COVID is the orbital surgery with the dacryocysto-rhinostomy. All others can be considered as mild and moderate risk only. Any step where you're going to put in a personal protective equipment, the first step and the last step of PPE would be the hand washing according to the WHO guidelines. Donning and doffing remain the same. How do we calculate the employee as the low risk, moderate risk, or high risk will depend on the patient, duration of exposure, employee's job, and the personal protection equipment. So we categorize them as 0 low level. The administrative staff and canteen staff, they have the 3-layered cloth mask. Patient and no contact, they can maintain a distance of at least 1 to 2 meters. Just a 3-ply mask would be good. If they have contact and no aerosol generating procedures, a respirator is ideal. If the contact is there and AGP is possible, apart from the respirator, we advise a face shield or a goggle. But during surgery, the face shield and goggle may not be comfortable for most of the surgeons. Between the mask and the 3-ply mask, the mask is the mother of all personal protective equipment. N95 is one of the best and protects you as well as the person to whom you're in contact with. But a well-owned 3-ply mask could be as good as the N95. The N95 respirators are actually single use, 4 to 6 hours use. Because of the crisis, COVID-19 crisis, CDC has advised extended use and limited reuse for people who need it and prioritizing the use. Decontamination can be done in many ways. Air drying method is giving them 4 or 5 N95 masks. They use 1, 2, 3, 4 Monday, Tuesday, Wednesday, Thursday. On the 5th day, they'll use the first mask. So we dry it in between. The principle is the coronavirus, if at all it is there, will not be there in the N95 for more than 72 hours. The ultraviolet germicidal irradiation is one of the best methods that can also be done. In-house, we have developed a small, compact, effective UV irradiation for respirators, which can do 6 at a time. The whole process takes 30 minutes. And these can be used on alternate days. We give 1 day period in between for it to be worn. It can be done up to a maximum of 10 times. This is amazing statistics, but very sad that we use 89 million masks, 30 million gowns, and so on every month. So we should also be careful how we dispose them. These wastes are becoming multifold, increases there. Whatever pandemics come and go, the face cover, the medical masks are eternal. That is the most important personal protective equipment to protect us. What is going to remain the same is the perioperative antibiotic protocols, whichever is working well, including the intracameral antibiotics, autoclaving and protocols, biomedical waste management. Only if we are dealing with COVID-19 positive patients, the biomedical waste management changes. Otherwise, non-COVID hospitals, it will remain the same. We have to maintain the OT logs, all entries as needed. This coronavirus can spread so rapidly like the stealth. Very easily it contaminates and spreads to people. But easier than that is to decontaminate this coronavirus, which is a good news. Even temperatures of 70 degrees will kill this virus. Any number of solutions are available, sodium hypochlorite, Lysol, isopropyl alcohol, and so on, or 70% ethanol. So these are very effective against the coronavirus. Only thing is we must understand what to clean, when to clean, and how to clean. You need to have your disinfection protocols for OPD and OT, where when and what and how long it should be clean. The validations of sterilization using physical indicators, chemical indicators, and biological indicators are very, very essential to make sure that our autoclave and sterilization procedures are excellent or in place. As I said earlier, in spite of all these efforts, there is still a chance of getting COVID-19 from an asymptomatic person. Any legal implications as far as we are concerned, there is no restriction of any patient, attender, or a staff to go to the court saying that from this hospital I got COVID-19. There are some of the consent forms which are very important and will be very important evidence in the court of law. It is not going to be easy for anybody to prove that hospital is alone the source, but still these things will help in the court of law. Claim may not stand in the court of law at this point in time because of the pandemic. It is always good to have a good task force to answer all the questions. What is the standard operating procedure, how to document, and how to continuously audit to make sure implementations are good. What to do when there is a suspicious or a COVID positive patient, attender, or staff. If a cluster occurs, what will be the decisions to be taken, what to be cleaned, and finally, it has to be reported internally according to the hierarchy and externally to the health agencies or the health department, because it is a notifiable disease at this point of time. These are the consent forms we take from the patient. Externally, in India, we monitor the movement of the patient and attender through this app. Internally, we monitor every movement of the patient with these registers to see that who all they have met, where all they have gone, and so on. We have a good protocol placed in all the places to identify where they have a problem, when they have a problem, whom to be contacted, where it is to be referred. So this should not be taken at the last moment. These should be nice, and every employee involved should be aware of it. The staff consent goes a long way. In our hospital, every patient undergoes a temperature recording, pulse oximetry recording, and every day their symptoms are asked for. Initially, they are categorized as mild risk or no risk or moderate risk or high risk based on their age, based on whether they have diabetes, hypertension, cardiac status, or on immunosuppressants. This is going to be a good workup done every day so that you can screen them on a daily basis, whether it is the day scholar or the staff. Similarly, we have these protocols. Training plays an important role in times of COVID-19. As far as possible, if you can do it online, even within the hospital, it will be wonderful. Or if you're going to have it, you have good social distancing, the way they come in, the way they sit, and the way they go. With human resources, take care of the training regarding infection control and various COVID-19 updates and protocols. Posting of the staff as per shift system, screening of the staff. So it is important to give proper health care advice whenever they are needed. Plus, whenever there are deviations, we do a root cause analysis, corrective action, and preventive action will be undertaken. The feedback serves as a very good tool to take care of all the things whenever we have to make changes. Like the ASHRAE American standards, the Indian standards we have, this talks about heating, ventilation, and air conditioning. There are concepts of negative pressure as in COVID-19 wards, but it is not that easy to do it in a theatre. And in India, it will cost us about 6 lakhs to change one HVAC in a HEPA filter theatre. We can increase the fresh air component. We can use filters like HEPA or ULPA. HEPA takes care of 0.3 microns. ULPA takes care of 1.2 microns. These are all there. But we need to understand a temperature of 24 to 30 degree would be good in times of COVID-19. And the relative humidity, if it can be recorded, should be around 40 to 60 degrees, 60 relative humidity. The UV light is one of the powerful weapons against coronavirus at 265 nanometers. In-house, Aurolab has developed several things. Cost-effective UV lamps are placed in the AHUs to make sure that the air entering the operating theaters are clear and free of coronavirus. In secondary surgical centers where we have only split air conditioners, we have this HEPA filter-based room air purifiers which filters the air inside. Now we have the prototype being developed which has HEPA filter, UV lamps and ionizer, and it is very effective. It can serve a room of about 400 square feet. The take-home message would be a good screening protocol to any person entering the hospital, protocols for HIC practices based on COVID-19, staff health and well-being should be taken care. Whenever there are deviations, you should have plans in place to make sure the virus does not spread to other people and cause a cluster. These are some of the important references we have taken. It is optimistic for us to be very looking at early pandemic end. But the current status, we are not sure. But it is possible to create COVID-19 free zones across the hospital and theater with good screening protocols to the maximum possible, if not 100%. I'd like to thank Aurolab and all of you for this patient attention. It has been a great occasion to talk to you all. Thank you so much.